Good evening, everyone. On behalf of Inta Pharmaceutical Limited, I, Dr. Mithilesh Naik, welcome you all to this fourth episode of Endocrine Talk Show. And today we are going to discuss about one of the important aspects in managing diabetic patients, that is the coexisting dyslipidemia. As we all know, the guideline clearly recommend that every diabetic patient should be on statin therapy. But there are many challenges to it. And today we are going to dissect that various challenges, how we can better manage our patients who are suffering from the dyslipidemia in diabetes. And to guide and moderate today's session, we are having with us our course director, Dr. Shubhankar Chaudhary sir. He's a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. He's a former editor-in-chief for the Indian Journal of Endocrinology and Metabolism. He's a past president for Endocrine Society of India and past secretary for RSSDI. He is also a member for Subject Expert Committee, CDSCO, Government of India, and he is a founder patron for Southeastern Federation of Endocrine Society, and he's having multiple publications to his credit. So without further ado, I hand over the digital podium to Chaudhary sir. Over to you, sir.
So you can start. You have been introduced already by Dr. Nayak, so if you can start.
Okay, great. Very good evening, all of you. And it's wonderful to be back with this program, Endocrine Talk Show. And this evening, we'll discuss a very important area in management of diabetes, especially type 2. And we all know it's a holistic treatment that we need to offer. And as part of that, dyslipidemia comes very high on the list, often ignored. And if we look at the three different components, hyperglycemia, hypertension, and dyslipidemia, I feel the easiest to treat is dyslipidemia. Possibly hypertension comes next, and hyperglycemia control is the most difficult component. And sometimes we spend all our effort on controlling hyperglycemia only. So it's important that we understand when to treat, how to treat dyslipidemia and type 2 diabetes. And to take us through this difficult area, we have 4 wonderful people from across the country, experts, well known in their own fields. We have Dr. Ambrish Mittal. How do we introduce him? He's a Padma Bhushan Bishiroy awardee. He's been a past president of Endocrine Society of India. He's been a past editor-in-chief of the Journal of the Endocrine Society of India. And he is a very well-known name in the field of osteoporosis, not only in India, across the globe, and has had numerous awards in this field as well. So welcome, Ambrish, to this program. We also have Professor P.K. Jabbar, who is professor and head of the Department of Endocrinology at Government Medical College in Trivandrum. He is also director and CEO of the Indian Institute of Diabetes at Trivandrum. And this evening, I am happy to be part of his program at Trivandrum itself. And he's got many publications to his credit. We also have Dr. D.C. Sharma, who is an endocrinologist par excellence from Udaipur. He's a senior consultant and director at the Institute of Endocrinology and Diabetes at Strajan Hospital. He's also professor of medicine at Ananta Institute of Medical Sciences in Udaipur. He has also held various other important chairs, published widely in national and international journals. And these are all the endocrinologists, but we are fortunate to be joined also by a very reputed cardiologist, Dr. Arun Chopra, who has been on the faculty and the Department of Cardiology at AIIMS New Delhi, but currently is Director of Cardiology at Fortis Escorts Hospital in Amritsar. And he is a very well-known name in interventional cardiologist. So welcome all of you to this evening discussing about dyslipidemia and diabetes. So to take us through, while our prime focus this evening will be on type 2 diabetes, can we first have Dr. D.C. Sharma tell us about dyslipidemia in type 1 diabetes? Probably we will not come back to this issue much. So let's complete with type 1 diabetes and dyslipidemia. Do we also need to treat them with statins?
Yeah, thank you.
And while DC gets ready, let all our participants, all the audience also continue to send their questions so that we can put before this August panel. Yes, DC.
Yeah, thank you, Dr. Chaudhary. Good evening, everyone. Before I elaborate upon type 1, but let us understand that the basic pathophysiology of dyslipidemia and type 1 diabetes and type 2 diabetes is different. There is pure insulin deficiency in type 1 diabetes, leading to abnormalities in the lipoprotein lipase, while there are other abnormalities in addition to insulin resistance in type 2. So in type 2 diabetes, basically insulin resistance leading to increased lipolysis of adipose tissue with the high free fatty acid plasma levels and reduction of the ApoB degradation in the liver. Furthermore, insulin resistance promoting the production, secretion of more atherogenic VLDL particles from the liver with an increased plasma concentration of small dense LDL particles and reduction in HDL particles. In contrast to this, the abnormality in type 1, as I mentioned, is insulin deficiency. And this insulin deficiency leads to several qualitative as well as quantitative abnormalities. In fact, the lipid abnormalities in type 1 depends on so many things, like glycemic control. This holds true for type 2 diabetes as well. So glycemic control, duration of diabetes, age of the patient, weight of the patient, diet, exercise, and presence of nephropathy especially. So say, for example, in an uncontrolled type 1 patient presenting with mild hyperglycemia and say maybe in the ketosis, the predominant abnormality is because of the lipoprotein lipase not being inhibited by insulin. There is hypertriglyceridemia. There is marked increase in the FFA, free fatty acids, with hypertriglyceridemia. LDL may be normal or low, and HDL is low. In contrast to this, in optimally controlled type 1 diabetes, the lipids may appear totally normal. Say, triglycerides are normal or slightly low. HDL may be normal or slightly raised. LDL may be normal or slightly low. And this, in fact, is maybe because some speculation that exogenous insulin therapy or the subcutaneous insulin therapy leading to slight hyperinsulinemia may be responsible for this set of lipid levels in type 1 diabetes. The story is different when a type 1 diabetic patient gets nephropathy, because once a type 1 diabetic patient gets nephropathy, there is a 37% higher chances of he's developing atherosclerotic cardiovascular disease. And with nephropathy, the lipid abnormality changes. There is high LDL levels, low HDL levels, and maybe triglyceride levels are also high, making him at a very, putting him at a high risk of atherosclerotic cardiovascular disease. So this is the lipid abnormalities in type 1 patient.
Yeah. So, but essentially, that's insulin resistance also is deficient insulin action. So whether the insulin is deficient or it's not able to act. So do we also aggressively treat dyslipidemia in type 1 diabetes?
Yeah. Right. This is an important question, and especially talking about statin therapy in type 1 diabetes mellitus. See, when patient present, number one, glycemic control, because with controlling blood glucose, triglycerides will be settled and everything will be all right. So as such, lifestyle measures, exercise, diet, getting him to normal weight, these are first recommended. Regarding drug therapy, statins are not indicated in children below 10 years of age. And above 10 years of age, statins are indicated if LDL levels are more than 160 milligram per deciliter. And also if LDL levels are more than 130 milligram per deciliter in presence of other risk factors, one or more cardiovascular risk factors, then again statins are indicated. In contrast to type 2 diabetes, we have plethora of evidence in favor of statins. Very few studies, long-term trials are available in type 1. But I've mentioned the statins
Right.
in children
Right.
above 10 years of age.
Sure. Now, especially in the context of diabetes, getting a lipid profile sometimes becomes a little bit tricky when we are supposed to observe 12 hours fasting. And sometimes labs are very sort of make it very sacrosanct. It's 10 hours. No, we won't take the sample. You can go back. So sometimes people also tend to become hypoglycemic if for example, they have fasted for too long and when they're on insulin. So the question is to Ambrish. So do you think non-fasting sample could not do in many cases or in most cases? Is there a whole lot of difference between maybe 8 to 10 hours fasting versus 12 hours fasting for lipid testing?
Thank you. Am I audible? Yeah. Thank you, Shubhankar.
Yes.
I think that's a very fundamental question, and trust you to make it seem so simple, actually. But the thing is that this, obviously, because of the way we were taught physiology, fasting was considered very, after a meal load is about 14 hours or at least 12 hours. So the thing is that why was this considered sacrosanct? Is simply because you're looking at a more consistent standard band, because there might be a lot of variations with the diet, which may not, necessarily be reflected in the normal ranges, all those things which are designed basically for that. And the idea is to reduce those differences and to make it more standardized. That is how fasting samples were taken. Now, of course, the other point is that there can be major changes in lipid profile in fasting and non-fasting. That was the impression that we were all brought up with. The hospital where I worked before this said, you have to come fasting 14 hours. This is not even a cup of tea. It's written in bracket in capital, but people think that having tea is okay. Anyway, so the fact is that more and more evidence, when people looked at this very clearly, something I just copied from book to book down the decades, when people started looking at this, that why not non-fasting, then people found the following things. Number one, we all know that fasting is convenient. Non-fasting is convenient. And fasting is inconvenient and may often mean a second visit of the patient, which may be impossible or difficult. And for reasons Dr. Shubhankar has already outlined, in some patients with diabetes and all, a prolonged fast can cause an issue, right? So number one is the convenience of sampling in non-fasting. So why not non-fasting? What is the difference in the fasting at fed state in the values per se? What was found actually, so in the fasting state, it's only the liver that's contributing the bulk of lipid, the LDL cholesterol especially. Whereas in the fed state, it is the liver and intestinal sources that are both contributing. So what is the difference? The difference is that the triglycerides, they vary, but on an average is about 25 milligram higher in the fed state than in the fasting state. So average, there's variation there, but average consistent across various studies. And I think in the position papers of both the European and American cardiology societies, it says that the difference in triglycerides is typically 25. So that's good to remember, in that zone, somewhere in that zone. Now, on the other hand, you'll be surprised, some of us may be surprised to hear that the LDL and total cholesterol actually don't vary at all. If anything, they're marginally lower, because the liver production actually goes down a little bit in the fed state and intestinal component increases. So actually the LDL in non-fasting state is on an average 8 milligrams lower than in the fast. So it's important to understand, same with total cholesterol. So it's important to understand that triglycerides are slightly higher and LDL and total cholesterol are actually not affected much, right? So therefore, the difference is not as striking as we were led to believe all these years. The second point is that what is the predictive value? There are studies which have clearly shown that the predictive value of non-fasting lipid profile in terms of cardiovascular outcomes is similar to a fasting lipid profile. So we have an idea of the changes, which are not dramatic, a little bit in triglycerides, but not too much. Secondly, it's convenient. Thirdly, we know that it also predicts cardiovascular disease in the same way as a fasting sample done. So what is the caveat? Now, in the non-fasting state, LDL of 115 is considered okay. Triglyceride 175, total cholesterol 190, and a non-HDL of 150. So let's say LDL, we think of 100, we want below 100. In non-fasting, some people say there's variation, is that you can go to 115, even though mean value may be slightly less, but this is what they say. And triglycerides, you investigate above 190 as abnormal. So there is a different cutoff, right? And yet these values, a non-fasting sample can be used very easily. The caveat again is that if the triglyceride levels are above 400 or 440, some studies say, then you have to do a fasting sample again, because then the whole sample may not give you an accurate reading at all. So especially now, in my center, for example, in our center, and so many of you must be using, we use a lot of point of care testing, which we have standardized over 3 months before we started using. So the use of non-fasting lipid profiles has dramatically increased in the OPD. Like you get an HbA1c and random sugar done, we also do a lipid profile. So there is very little to really, and most international societies have agreed and recommended this. Perhaps UK has not done that yet, but I know that US and most European countries now recommend non-fasting samples. And the last point here is that the votaries of non-fasting samples also say the same thing they say for glucose, that much of your day, more of your day is spent in the fed state than in the fasting state. And therefore, why not look at the lipids in that state when they will be affecting the vasculature or vessel wall more in the non-fasting state. So these are the
Right.
points.
So that's encouraging and useful for patients and doctors also to know that non-fasting could also do. And actually, though UK may not officially have accepted, but I do remember even way back in 1996, 97, when I was there, I do remember we used to run clinics in the afternoon, and
yes,
samples were drawn even then. And only when you had significantly abnormal values, especially triglyceride, would they be called back for a fasting. So thank you very much. And Dr. Mithilesh, I would request, because of some technical challenges at my end, if you could take the questions at the end from the audience, that will be easier.
Sure.
Right. And so since we have a cardiologist on board, let's get Dr. Arun Chopra to tell us about statins and diabetes. This is something that we've been hearing since I think the Jupiter study with rosuvastatin. So how big is that a problem? Do you see that a practical hindrance to the use of statins in non-diabetics?
Hi, good evening. Sorry
Hi.
for joining in late. My flight got delayed. But I heard Dr. Ambrish's exposition about non-fasting samples, and I agree totally. Most of our guidelines also now recommend the same thing. Just keeping in mind that apart from hypertriglyceridemia, even in diabetes and metabolic syndrome, there may be a disconnect between the serum LDL levels, which are especially those which are calculated, and the LDL particle number. Therefore, in these conditions, a particle number or an ApoB level may be more predictive. Otherwise, on a population level, a non-fasting sample is perfectly acceptable and the way to go. What you talked about statin and diabetes, you know that there has been a lot of controversy about this. The published data from RCTs and from observational studies is widely different, and this is the cause of the problem. So if we look at RCTs, the excess of diabetes over 4 years of treatment is about 0.5 to 1%, or 50 to 100 per 10,000, as has been published. This is not a particularly large number, because the amount of survival benefit that you get from appropriate use of statins in high-risk conditions would actually be much more. However, having said that, we need to see why is there such a difference between the reports of observational studies or registries and the reports from RCTs. So the fact is that RCTs
Maybe we lost Dr. Chopra's audio.
Can you hear me now?
Now I can hear you. Yes.
Sorry, I lost the signal. The difference is that RCTs, reject about 35% of patients who initially in the first run-in period of 6 to 12 weeks develop statin toxicity of any sort. So all such patients are removed from RCTs, which is why we have much less withdrawal from RCTs, which is why we have much less toxicity from RCTs. But if we look at registries where there are all comers, there the toxicity is actually higher. And that is why we are not able to reconcile. So if we look at data from, let's say, Women's Health Initiative, there was a 48% excess of diabetes. If we look at Jupiter, where overall there is a 25% excess of diabetes, women actually had a nearly 50% excess of diabetes, which is similar to Women's Health Initiative. So the point is, how significant is this? So I think what we need to look at is that if the patient falls in the category where you get survival benefit out of statins, which is clearly secondary prevention subset, people who have established ASCVD definitely get a benefit, no hesitation here. People who are at high risk for primary prevention, this includes familial hyperlipidemia, this includes people with ASCVD risk more than 20%. There is really no controversy. It is in the lower risk subset, whereas see now AHA, ACC, etc. are recommending statins in the 7.5% plus 10-year risk. So this is the subgroup where we need to watch out. And here all I would like to say is that since we know that high dose statins are associated with a greater risk of diabetes, perhaps the way to go in primary prevention is moderate dose statin. If we look at the ED50 of atorvastatin, it's about 3 milligram. So 20 milligram is nearly 90% of the efficacy of 80 milligram atorvastatin. So a 20 milligram dose should be good enough, doesn't cause too much diabetes, doesn't cause too much intolerance, and should be quite okay in most primary prevention patients. This would be my summary.
Right. So with that assurance, let us come to Dr. Jabbar. In type 2 diabetes, which is often stated to be a cardiovascular disease equivalent, what should be our approach and what is actually practiced? There is a suggestion that practically everyone with type 2 diabetes, especially maybe above the age of 40, should have a statin. Is that what's widely practiced, at least by the diabetologists?
Good, sir.
Professor,
Very good question. Very good question, Subhankar, sir. I think I have to be very careful with this question because you asked me irrespective of age. We'll discuss that point. Before that, if you look at the diabetes like dyslipidemia, the characteristic dyslipidemia by various authors reported as normal or mild increase in LDL. Triglyceride is also little elevated depending upon the glycemic profile, and HDL is also reduced. That is what is happening. But GARG papers very clearly said little conflicting, but one of the important finding is low levels of HDL. Now coming to the LDL level, there are various thought processes and various people, they are all giving statin for all patients irrespective of LDL level. When I was a student for DM, it was 130 was the cutoff, subsequently reduced to 100, then again reduced to 70, 40, something like that. So you are theoretically and practically speaking, always you should measure LDL level. There is no doubt about that. That's a usual dictum also. But LDL is again a funny molecule. If you see the Selby's article, there are 3 or 4 types of LDL. The most important factor is small and dense LDL, which we are not picking up in routine clinical practice. So in patient with type 2 diabetes, this small dense fraction is dominating. And that may be the reason people are thinking, even from Europe, even from India, people are thinking that better to go for lipid treatment or LDL or statin treatment for all patients. Even though currently we are all measuring this LDL, but see, measuring has got its own issue. That is number one. So better to start statin for all patients. Second point is the age factor. We can call it as productive age and non-productive age. After 75, of course, that's an optional medication. But Up to 75 or between to 40 to 75, I think all patients should go for statin. As per the textbook, high dose statin. At least, you should maintain your LDL level to a range around 100 minimum. And high risk patient, definitely better to go for very strict control, probably 70, probably less than that. So these are all my comments. So for all patients, statin is indicated. There is no doubt about that. Okay, over to Subhankar, sir, please.
Right. Thank you. So once we start a patient of type 2 diabetes on statin, what is the target LDL? Maybe Dr. Ambrish, if you would touch upon that important area, or is it just to do with moderate dose, high dose, or is it an LDL level that you're looking at?
So I think it's a bit of both. Quite clearly, to simplify things, the guidelines now don't focus so much on the LDL level alone, and they do talk of moderate and high dose regardless, because recognizing the fact that statins may have benefits beyond LDL lowering. So that's one part. But still, every guideline you will read will give you a number to aim for. Right? And our ADA guidelines and our Indian guidelines and whatever. So what are the numbers we should aim for? In general, as all of you are very well aware, the number is 100 LDL. We're talking of first, we're saying LDL is by far the most important number we are looking at. Everything else is second. And basically, we are looking at LDL and we are wanting it below 100 in everybody. No question. We are also wanting it below 70 in those who seem to be at significantly high risk or have had history of events in the past. And in some of them, you may want targets of below 55 or 50 also, those who are progressive disease despite all efforts. So it is the targets for different kind of patients can vary between 50 and 100. There are people who go to the other extreme, that lower the better, but this is a fairly practical recommendation based logic. So that is number one. But it doesn't stop there. There's the whole concept of non-HDL lowering also. Non-HDL. Well, okay, even before I go to that, there is also a concept of LDL percentage lowering. Not just this. And that says that in those who are at higher risk, just achieving this 100 or 70 may not be okay. And you would require an LDL lowering of at least 50% in those who are at very high risk, 20% risk for 10 years, that kind of group. And for that, if you have to use ezetimibe, even that's okay, in addition to statin. So maximal statin tolerated plus ezetimibe. So in this group, you are saying LDL 170, 50, that as I said, then not percentage LDL lowering, not for everybody, but in the highest risk group amongst this should be at least 50%. And the third is that you also look at non-HDL. And the non-HDL cholesterol is total minus HDL cholesterol. And why should we look at that? Because the primary abnormality in people with diabetes is not LDL in general. The blood glucose abnormalities and the whole metabolic syndrome raises triglycerides and suppresses HDL rather than raising LDL cholesterol. So non-HDL, a rule of the thumb to remember is 30 milligram more than the LDL target. So whatever target you're choosing for, that also helps because it brings in the apoproteins and others into the picture and they are measured there. So this is how we set the targets. Number one, LDL less than 100 or less than 70 or less than 50. Two, LDL lowering of at least 50%, even if it requires more than statin. And three, you would want a non-HDL target also to be achieved.
Right, that's clear message. Can I have a quick one from Dr. Arun Chopra?
Yes.
Yes, please.
Apart from LDL or HDL, is there any merit at looking at LDL HDL ratio? Dr. Chopra?
Yes, please. I think that's a very relevant question because if you look at the studies, the best predictor of coronary artery disease or CVD outcomes is actually ApoB over ApoA ratio. And the best available approximation to that is total cholesterol over HDL ratio. Not LDL over HDL, but total cholesterol over HDL ratio. It comes closest to ApoB over ApoA1 ratio. So these are the two best predictors of ASCVD. They are both better than LDL levels alone. Therefore, this is one point. The other point which I would like to add to what Dr. Mittal was just saying is the importance of remnant cholesterol, which is total cholesterol minus HDL minus LDL. And this remnant cholesterol more than 30 has attracted a lot of interest in the last couple of years. There have been two large population trials, the Predimed study and the Copenhagen General Population Study, both of which have shown that in patients who are largely on low dose of statins, half of them are taking about 10 milligram of atorvastatin. In them, the best predictor of MI is not the LDL level, it is the VLDL level or the remnant cholesterol level. And therefore, this needs to be addressed.
Right. Thanks.
So which is why this difference of 30 is important. So which is why you may have an LDL that's normal, but a non-HDL that is significantly higher. And that is exactly,
Absolutely.
so I think that's a very good point, Dr. Chopra. Yes.
Right. So that brings us back to the issue of 10 milligram of atorvastatin. So remember the CARDS study, that was one of the few studies in type 2 diabetes which suggested significant benefit even with just 10 milligrams of atorvastatin. So is there any rule for this? Because even moderate intensity statin will mean at least 20 milligrams of atorvastatin. So Dr. DC Sharma, what do you suggest?
Yeah, Dr. Chaudhary, in fact, I agree with you that 10 milligram of atorvastatin or maybe 10 to 20 milligram of atorvastatin and equivalent Rozua, that is 5 to 10 milligram of Rozua, would be called as moderate intensity statin therapy. And this much dose would be, indicated for primary prevention, especially when the LDL cholesterol is at target, that is less than 100. You can continue with, or you can initiate with 10 milligram of atorvastatin, would give you a lot of benefits. And as already been discussed by Dr. Jabbar and Dr. Mittal sir, who are the candidates for this much dose of 10 to 20 milligram of atorvastatin? All patients, all type 2 patients, between 40 to 75 years of age, without ACVD, without established heart disease, and with the, of course, with the lifestyle therapy. And patients between 20 to 39 years of age with additional risk factors for heart disease. They are also to be initiated on this much dose of statin, especially when your LDL cholesterol target is met. I've already talked about type 1 diabetes. There are more than 160 milligram LDL and also more than 130 milligram in type 1 when additional risk factors. So basically this much dose to be initiated in all type 2 patients for primary prevention of ACVD.
Right. With
that was, if with due respect, if I may add here, Dr. Shubhankar, I was just telling you earlier about this, that the ED50 of atorvastatin is just 3 mg. And therefore at 20 mg, it is at nearly 85 to 90% of its efficacy at 80 mg. So 10 to 20 mg is actually a fairly good dose for primary prevention. I had given the justification earlier, and I think that is exactly what the previous speaker was saying, and I absolutely agree with him in this regard.
Right. So I come back to you, Dr. Chopra. Today, the general stress penchant is for high dose statins. So how tolerable are high dose statins, A? And do you need a regular, frequent biochemical monitoring apart from the lipids? Do you need to look at the liver function? Do you need to look at CPK on a routine basis in those who are being prescribed high-dose statins?
That's a very interesting question, one which has been very controversial. Fortunately, now we have more data about this, and high-dose statin is reasonably well tolerated in patients. See, what I find is that the tolerability is good in patients who are not, previously biased about it. You find patients who are previously biased about use of statins, drug for that matter, and they tend to have more side effects. They are better read and they tend to have more side effects. However, if we look at general population, one thing is that there would be at least 2/3 of our population. Now, I'm not talking only of diabetic individuals. I'm talking about all people on statins. At least 2/3 of these patients would be achieving their LDL target goals of around 70 with a dose of 20 to 40 mg. And in most of these patients, we don't have to go beyond this dose. However, there are at least 10-20% patients in our practice who don't achieve targets with even full dose. They are the ones who are on the actual high dose, 80 mg. So in them, intolerability is definitely an issue. As we know now from studies, 10 to 20% of patients complain muscle symptoms, but all of them don't go away when statins are stopped. So maybe half of them would have actually benefit if statins are stopped, but nearly half of them continue to have those symptoms even if statins are stopped. Therefore, their symptoms are probably not statin associated. That is one issue, because in the elderly individuals, in individuals on multiple drugs, and individuals on CKD, already they have all these muscle symptoms. Now, who are the patients who are especially, more likely to be statin intolerant? These are patients who have CKD, untreated hypothyroidism, elderly individuals, especially more than 70, people who are also taking a fibrate in addition. So these would be some of the conditions where people are more likely to be statin intolerant. And they are the patients in whom we have to check all these biochemical parameters. Regarding routine biochemical parameters, initially when we start, of course, we have to check creatinine, we have to check LFT, we have to check thyroid function, because untreated hypothyroidism is a contraindication to initiating statin therapy. Excuse me. So after that, on follow-up, FDA does not mandate routine LFT, even though it is done as a routine, because we know that there is elevation of liver enzymes in 1 to 2% of cases on high dose statins. However, LDL does not really support, FDA does not really support this. So what I would do in my practice, I would check at 6 months the LFT. Earlier, if a patient has any symptoms, otherwise I would usually check at least 6 months. I would also check creatinine, because high dose statins have been associated with a somewhat higher risk of AKI. So I would also recheck creatinine in these patients. Apart from, excuse me, apart from, of course, thyroid functions in the beginning. And if it is a treated thyroid, then of course one would continue to look at it at least on an annual basis.
What about CPK?
It is, CPK is not recommended normally unless the patient has severe muscle symptoms. We don't routinely have to get CPK done, because in most patients who have statin-associated muscle symptoms, CPK comes out as normal.
Right.
So we don't need to check them routinely. LFT, we can check once. Creatinine, thyroid, not necessarily afterwards. And we should check sugars, because there is some evidence of minimal increase in HbA1c of 0.1 to 0.2 in the long run. And we don't need to check LFT routinely on every visit.
Right. So can I ask Dr. Mittal, with the new launch of bempedoic acid, now that's available in our country, so many pharmaceutical companies have come out with it. So what is the scope of this agent? I mean, is there a large group of patients that you see who are intolerant of statins, or do you feel that you do not reach goals in a significant number of patients with statins that you need something like bempedoic acid? Dr. Mittal?
I'm not very enthusiastic about it. I mean, of course, anything can be marketed. It's all right. It's good. It's an additional tool. But if people don't reach the goal that we would want them to, with the maximum tolerated dose of statins, then one would tend to add ezetimibe, which has been there. So I don't know, maybe you have a better idea whether this new molecule is making a huge difference worldwide or anywhere in our management. I don't think, to be honest, I think statin intolerance in clinical practice, at least in our patients, is not very common. It's also hard to figure out because they're often older patients who have some aches and pains and some this and that. So it's very difficult and they have diabetic neuropathy and cramps because of that, So it's not so easy, vitamin D deficiency and cramps because of that. So it's not very easy to say this is really a statin effect. In only some we can really say clearly extrapolating that this happened after the statin. So I'm not personally sort of jumping with joy. It's good to have an additional molecule, that's all.
Absolutely. So let's see some of the questions that are already there in the chat box. Maybe Dr. Twari, any role of CoQ in statin-induced muscle symptoms? Dr. Jabbar, will you take that?
Yeah, it's a good question. In fact, say statin, as my previous speakers were discussing, the chance for significant muscle disease is not very high in our clinical practice. So how to prevent that? Of course, so you can go for sufficient dose. Combination probably may be avoided. Concomitant administration of certain drugs can produce problems. And if the patient has got hypothyroidism, need to be corrected. And if the patient has got renal dysfunction also, all these, the predisposing factors will look into. If nothing is there, we can look into the vitamin D level. You need not measure vitamin D level, but vitamin D as the replacement or sufficient amount of vitamin D also may be useful for preventing this issue. Coenzyme Q10, whatever, which is one of the molecule may be useful for reducing muscle disease, but we are all not, at least for all patients from my side, we are not giving. But there are theoretical information this may be useful. So we are not using it because two reasons: we are not seeing a lot of cases of muscle issues, and of course, because of that, we are not giving coenzyme Q10. That's it, sir. Over.
Right. Thanks. There's another question, Dr. Pathak. Any role of ezetimibe in managing diabetic dyslipidemia? Dr. DC Sharma?
Yeah, right. Basically, ezetimibe comes when maximum dose of statin or sufficient, high intensity statin therapy is given and still you're not at the target of LDL levels. Then ezetimibe may be added to bring LDL further to the target, especially in patients who are receiving high intensity like 40 milligram or rosu or 18 milligram or atorvastatin in secondary prevention. Patient already had an event and LDL is still high. Then ezetimibe may be a molecule which can be used, or the other molecule which you were asking, Dr. Mittal, can be used.
Right, but with bempedoic acid, do we have endpoint
don't have
studies?
Yeah, yes,
outcome.
correct. Even the
Right.
ADA 2022 guidelines say
Right.
it can be used, and there is some role, but studies are required. This is the clear,
Right.
So
statement.
bempedoic acid does have studies, but those studies are basically LDL level lowering studies. It doesn't have outcome study. The clear outcome study is ongoing, and the results are expected in another 2 years or so. So far, the information we have is if added to high dose statins, it brings about an extra 17-18% reduction of LDL. If used alone, it brings about 20 to 30% of reduction. And if used with ezetimibe, it brings about a 40% reduction in LDL. So this is the information we have. We don't have outcomes data. And that's why we are still not extremely enthusiastic about it. We are waiting for that data. That should take another couple of years or so.
Right. And Dr. Chopra, Dr. Shinde wants to know how long should we continue high intensity statin in high risk diabetic patients with LDL-C of around 160 to 180, triglyceride 200.
So this is practically lifelong therapy. So we know that at least until the age of 75, there is clear evidence of benefit and therefore till that age we are going to continue with this drug. After that, after 75, if a patient has established ASCVD, then of course we continue with the maximum tolerated dose, which may no longer be high dose, which may be a more moderate dose. But if the patient has no evidence of coronary artery disease or stroke at age of 75, guidelines are really not extremely clear. What they say is that if the patient is tolerating, you can continue, even though the number of individuals over the age of 75 who have been in these trials and have shown benefit is small, and therefore no conclusions can be drawn. So probably indefinitely, at least till 75.
Right. And since Dr. Amrish Mittal has already alluded to this issue, he may take up Dr. Singhania's question. Fed or non-fasting sample will be a postprandial or a random sample?
Random. We're talking of random samples.
Yeah.
So you haven't sanitized postprandial here. It is just fasting versus random.
Right. And do we have some more questions left? Yes. Anyone? Dr. Singha, what is the role of non-HDL cholesterol in management, when we should target it? Who likes to take?
No, I mean, I think we did emphasize, Dr. Chopra and I both spoke about it in different ways. But the truth is the patient is significantly high risk, then just LDL targeting may not be enough. And therefore, we look at a non-HDL target, which includes other predictors other than LDL. And therefore, and that difference, for example, if you have an LDL target at 80, let's say that patient's target is, or maybe 70, okay? And the non-HDL cholesterol is 120. So the difference is 50, that there is a problem. That means you must bring the non-HDL down also, so that it's at the target where non-HDL should be, which is typically 30 milligram more than the LDL target. So it means that 50 milligram, instead of being 30, it actually contains atherogenic components, which we are not treating if you're treating LDL alone. So to simplify, if you are looking at high-risk patients, it's a good idea to look at non-HDL also. In many of them, it will just be controlled without any problem with whatever you're doing. But if it is not matching up, if it is more than 30 milligram ahead of LDL, then you do need to, increase your dose or support your therapy further.
So there, do you think there is a role for non-statin treatment?
So if you, I mean, the same thing, if you're looking at see, when we're talking of cholesterol, then non-statin treatment is all a little hazy because outcome data is not so clearly available. But there is some data with ezetimibe. So the truth is that we are looking at things that will bring the LDL or non-HDL to target. Now, if we are not able to do that with the maximum tolerated doses of statins, then our good old ezetimibe can easily be added. But I see fibrate usage is very high. I'll make a small comment on that. And in India, people just add fibrates for everyone whose triglycerides are above 150 or 175 or, so I think that should not be encouraged. There's a limited indication for fibrate usage. And one should use it only when either there is severe hypertriglyceridemia or if you're struggling with your other parameters. Otherwise, it's not indicated for these triglycerides. You should perhaps, if the triglyceride is higher, you may want to push the LDL down further. That may give you more bang for your buck rather than bringing down triglycerides with a separate fibrate. So I think we do overuse it in general.
Right. Maybe Dr. Jabbar. So what about the homegrown saroglitazar and with effect on triglyceride, with effect on glucose control, and maybe even on non-alcoholic steatohepatitis?
Good question, sir. See, nowadays, just like our diabetes mellitus, there is I would just for an exaggeration discussion, pandemic of non-alcoholic fatty liver disease. Such a common situation, even we have seen a lot of cases in our place, Kerala, see the incidence is touching up to 30 or 35%. We have a study now. So how to reduce this non-alcoholic fatty liver disease? The best thing is non-pharmacotherapy, which includes a dietary modification and exercise. Of course, it's not that easy to practice. There are drugs. There are many drugs for that. Coming to the seraglitazole is one of the fanciest molecules, probably a promising molecule for reducing non-alcoholic fatty liver disease. We are all using it. I think the usual dose is 4 milligram. We are using it. And it's found to be useful, especially in the face of hypertriglyceridemia. It's a good molecule. We have good experience also. We are using it. And without much significant adverse effects and metabolic derangements. Over to Subhankar sir.
Right. Of course, we may not still be having the type of long-term data or large data to really prove beyond doubt that it's beneficial in the long run. But of course, there are some studies on the basis of which, of course, Drug Controller General of India has approved its use for this indication in our country. So a quick one from for Dr. Chopra, that is the role of HSCRP measurement, and is there an indication of using statin because of raised HSCRP despite maybe normal level of lipids?
So this is the question that the Jupiter study tried to answer. They took individuals with the normal LDL levels and then they gave them rosuvastatin in case the HSCRP was elevated. I think they used a cutoff of 2.5 or 3. So what we know is that an elevated HSCRP indicates a state of inflammation. However, it is elevated in all infections. It's elevated in after surgery. It's elevated after myocardial infarction, in any fever. So in a stable patient, an elevated HSCRP could indicate a systemic inflammatory state. And what we know is that there are several things which lower this HSCRP. Part of them are lifestyle changes like giving up smoking, like exercising, like a healthy diet. And part of the benefit comes from statins. So statins have been shown to reduce HSCRP. So we don't treat the patient for just HSCRP alone. But if we feel that LDL is high, the patient could be otherwise high risk. The patient is elderly, or at least I won't say elderly, maybe more than 50 or 60, and has risk factors. HSCRP would also come into the calculation. However, it is not a part of routine guidelines thus far. Routine guidelines are simple. They are, you treat all secondary prevention cases, all ASCVD should receive statins. And for primary prevention, they have outlined 4 clear groups, which includes diabetes, which includes LDL more than 190, which includes an ASCVD risk score of more than 7.5%. So all these need to be given statins. This is to keep it simple, because right. HSCRP reliable may not be available everywhere.
Excellent. So I think we had a wonderful session, a wonderful last 1 hour with all our experts. And what we understood is that lipids constitute a very important component of management in type 2 diabetes. Even in type 1 diabetes, there is a scope for using statins, but probably at higher levels of LDL than in type 2 diabetes. We did understand that strict 12-hour fasting may not be needed for measuring lipids, whether in diabetes or non-diabetes, for practical reasons, maybe more so in diabetes. We do understand that most patients with type 2 diabetes possibly deserve a statin, and possibly we use statins these days, not just looking at the LDL value, but also for its pleiotropic benefits. So possibly relatively higher doses of statins are indicated many a time. especially for secondary prevention in those who already have had cardiovascular event. We are also encouraged by the fact that not too many people actually encounter statin-related adverse events and tolerate it relatively well. And for most people, it is a sort of indefinite lifelong treatment with statin. Though, of course, there is paucity of evidence in its efficacy in people beyond age 75. But nonetheless, in real world, it often becomes difficult to say, now you no longer have any risk, now we'll stop your statin because you are past 75. So in most instances, I would possibly continue on statin if it's tolerated. So with these, I would like to thank once again all our panelists this evening, Dr. Ambrish Mittal, Professor P.K. Jabbar, Dr. Arun Chopra, and Dr. D.C. Sharma for their wonderful deliberations, and of course, all our audience across the country who have been keenly interested, have been putting in interesting questions, and it's really their participation that enthuses us to take this program month to month. And I would fail in my duties if I don't thank INTUS and its team for organizing this program. So over to the organizers.
Yeah, very good evening, doctors. Thanks. Actually, have given for the entire program. Today's endocrine talk show actually oriented towards a very commonly associated comorbidity with diabetes, and I think the panelists could discuss upon various facets of managing these patients, and I think you have appropriately summarized the same. On behalf of INTUS, makers of Dapavel and Lipicure, I would like to thank all our elite panelists, Dr. Ambrish Mittal, Dr. P.K. Jabbar, Dr. D.C. Sharma, and Dr. Arun Chopra for their contribution for the discussion. And we are ever indebted to Dr. Shubhankar Chaudhary for his guidance for the series of the program, keeping it interesting for our audience. We had almost 1,048 doctors attending this program, and we have just built on, with every program from here. So that's something wonderful to be having such an audience going from one program to the other. So for all the audience, I'm extremely thankful for your attendance. Wishing you all a great weekend, and I'm sure our future program will keep you excited as always. Thank you, doctors. Thanks a lot.
Thank you. A very good night to all.